Hello, everyone. So now we're going to continue talking about sulfonamides. It's another group of antibiotics that were used the very beginning of antibiotic therapy. So here we go. Okay, so sulfonamides and trimethoprim. So like I mentioned, usually when we talk about antibiotics that were used back in the 1940s, 1950s, the highlight is that all of them were broad spectrum antibiotics. That means that they will kill a lot of different type of bacteria, gram positive, gram negative, and because of that, they were overused until now we have resistance to them. The highlight of this is that both sulfonamide and trimethoprim, the way they work, basically they inhibit folic acid on the bacteria. That's the highlight that they inhibit for them to make folic acid. So that's something real quick. A big difference between mammals or humans and bacteria is that bacteria can make its own folic acid, where we have to ingest ours in the B complex family. So when the patient takes sulfonamides and trimethoprim, we're not afraid of the patient not getting affected because of lack of folic acid, since it's just part of our diet, versus bacteria that they make it. So these two antibiotics, they suppress uh, the different steps of making folic acid. So sulfonamides, let's start with those ones. Is what was one of the first antibiotics used back in the 1940s, 1950s. Like I mentioned to you, inhibit the synthesis of folic acid. So if they cannot make folic acid, they cannot reproduce. So that means that sulfonamides are considered bacteriostatic. The most common use is UTIs, and also can be used for nocardiosis. It's a bacterial infection, chlamydia trachomatis, this STI, uh, toxoplasmosis, this is a parasite, malaria is a parasite, and also can be used as part of the treatment for ulcerative colitis, trying to diminish the amount of bacteria in the GI tract, and that way we can heal that ulcer, that inflammation faster. But so far, sulfonamides, main use UTIs. Okay, here we have to be careful regarding adverse effects. It says Steven-Johnson syndrome. So this is an allergic reaction, but the highlight is that it involves the skin. So this patient is gonna start having bullous, uh, uh, like cysts with water in them, and when they burst, they're very painful, and this can kill the patient because basically the skin is detaching from the body, and that barrier protection we lose it, and it can get complicated with systemic infections. Regarding hematological effects, again, we have all the penias, anemia, leukemia, leukopenia, and so on. Kernicterus, this is seen on newborns, and basically here we have yellow skin or mucosa. So the patient basically turns yellow. They have icteria. Uh, Basically, it's liver damage, and we see bilirubin increasing. So this will give the patient yellow skin or mucosa. And also, they can have kidney damage because sulfonamides, if the patient gets dehydrated, it will turn into crystals. So this condition dehydrated patients. So this condition of crystalluria, we're gonna see it only in patients when they go into dehydration. So regarding sulfonamides, we have to make sure the patient understands that they need to continue drinking water, at least 2 liters of water per day. If they go underneath that, then uh, the medication will turn to crystals, and when the patient pees, can be very, very painful. So again, those will be the main adverse effects, the Steven-Johnson syndrome, which is like a reaction from the medication on the skin, where the skin is going to present a bullous. The skin will go into necrosis. So basically, the skin dies, and taking away that protection barrier from us, then we're going to have systemic infections. Regarding hematological effects, here we have the anemias and the penias, neutropenia, leukopenia, and so on. Regarding drug interactions, cross hypersensitivity. So this is very important to remember. So we have the word sulfur again, and we mentioned, okay, it's a sulfur, but remember what other medication from last week we mentioned. Those were, we're talking about diabetes. We mentioned the sulfonylureas. Also, now medication that has sulfur is furosemide. Tetracyclines, they have sulfur. So if they're allergic to sulfonamides, they're allergic to any other medication that has sulfur in the name, or to make it even easier on you, any medication that produces photosensitivity. So again, furosemide, sulfonylureas, tetracyclines, sulfonamides. So all of them, they produce photosensitivity in the patient. So if they tell you I'm allergic to sulfonamides, we have to assume that they're also allergic to those other drugs. So again, anything that has sulfur in their name, furosemide, cyclins as an examples. Regarding the resistance, again, going back as penicillins and all of them, because they were widely used with no control, no specific treatment, take it for 7 days, finish the whole bottle of pills, nothing like that. Eventually, and bacteria started making resistance to sulfonamides. And the highlight of bacteria is gonococcus. So meningitis is caused by the gonococcus family, gonorrhea, or meningococcus over here. So this will be better here. Gonorrhea. Regarding streptococcus, there's multiple infections like strep throat, skin infections, impetigosta. We have too many of them, and Shigella. And the disease will be shigellosis. Shigellosis is a infection of the GI tract, where we can have severe abdominal cramps, blood in stools, a lot of bleeding from the GI tract. Sorry, something got in the eye. So if not we don't take care of this patient, it could be fatal. Now, as I mentioned to them, sulfonamides, you can see here is related to silver sulfadiazine. So we have also sulfur right here, and mefonite. So these ones, they're not precisely considered antibiotics, depends on the author, but they are considered barriers. So what they do is they produce a barrier, especially on burn patients. We'll put silver sulfadiazine or muffinate, and that will do a barrier preventing the growth of the bacteria. And we have mentioned a lot regarding burn patients, Pseudomonas being the main one. Main things you need to learn is mephinite is painful when you put it on areas that has no skin. Unlike silver sulfadiazine, is pain free. Now with this, because they're applying areas without skin, you need to remember that mephinite is going to produce acidosis in the patient. So regarding these two drugs, silver sulfadiazine and mephinite, you're going to hear a lot regarding silver sulfadiazine because it's a more noble product compared to mephinite. Okay, the next antibiotic is trimethoprim. And same thing, it's going to interfere with the production of folic acid. So bacteria cannot make folic acid, so it cannot multiply, cannot grow. So we are suppressing growth, so this is a bacteriostatic. Same thing as sulfonamides. Trimethoprim is advised for UTIs, most common medical use. Regarding adverse effects, again, hematologic effects will go with anemias and all the other penias, leukopenia, neutropenia, lymphopenia, and so on. But the highlight here would be hyperkalemia. Long-term use of trimethoprim can cause hyperkalemia. So for this, you need to remember the lab value of potassium. And regarding hyperkalemia, the main organ that is always going to be affected can be the heart. Trimethoprim is safe to use during pregnancy and lactation, again, because we don't make folic acid from scratch. We need to have it in our diet. So it's safe to use it during pregnancy, especially because in this period there's a lot of UTIs and we need mild antibiotics with not a lot of adverse effects, and sulfonamide, trimethoprim are very safe during this period. So because of the resistance to antibiotics, it's very common to mix trimethoprim with sulfamethoxazole. Sulfamethoxazole is a sulfonamide, and the way they work, well, they're going to inhibit folic acid. So again, therapeutic use will be the UTI, but this combination, we're gonna have to highlight pneumonia by Pneumocystis jirovecii. Pneumonia by Pneumocystis jirovecii. And just real quick, Pneumocystis jirovecii is gonna be seen on patients with AIDS. So that's the highlight of this combination. Besides the UTI, is used a lot on patients that have HIV and they have a pneumonia by Pneumocystis jirovecii. Regarding adverse effects, well, it's because of the presentation, NVD, nausea, vomiting, diarrhea. Just like any other antibiotic, they can have a rash. We have to need to learn to see also the symptoms of anaphylactic shock. And in this case, a Steven-Johnson syndrome, all those formation of bullous with skin necrotizing, hyperkalemia. So we need to do follow-ups if the patient's gonna take this medication long-term. And usually with pregnant patients, the treatment is a week, 7 days, but those patients with HIV, AIDS, the pneumonia by Pneumocystis jirovecii, then we need to, those will take it for a longer period of time. So we need to make sure that they don't go into hyperkalemia. Also, make sure that those patients don't go into anemias or penias regarding the white blood cells. If the patient is a newborn, they may have kernicterus, and again, that's a mucosa skin that is yellowish. And every patient that takes this antibiotics, they need to be hydrated properly to avoid crystalluria. If the patient dehydrates, then it will be very painful for them to pee because they will be peeing crystals of the antibiotic. Okay, so that's all for this chapter. Thank you very much for your attention, and I'll be seeing you soon.